We're very pleased to be here to talk with you this afternoon about what we think are some pretty exciting training opportunities that we've been providing our students. So we are here today to talk with you about Reenvisioning integrated care training through community service, partnership, and collaboration. And I'll go through and introduce us all here just a little bit later. But I'd really like to start by giving you a little bit of background on why integrated care training, what makes that so important, and kind of why we've been experimenting with some kind of different ways to approach this. So first up, just what is integrated care? This is something you're all probably pretty familiar with if you've chosen to be here. This is probably something you're already interested in and familiar with. But this is the definition by the National Integration Academy Council. And they defined integrated care as the care that results from a practice team of primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. And when we kind of break that apart into its different components, we have three important pieces here. So primary care, behavioral health, and then perhaps some other health services. And that could include a variety of different services, so different allied health professions such as physical therapy, occupational therapy, nursing, etc. So integrated care is some combination of those three. And what we know is that there are potentially a lot of benefits to integrated care. So it certainly has been shown to allow more people to access mental health services. So this has been something that APA has been looking at very strongly, encouraging more psychologists to participate in integrated care because it's a way to reach people who may not find us in a specialty mental health care setting. So it's really increasing access to service. Something that I really like as a clinical health psychologist is that it facilitates a team-based, comprehensive approach to care. So it's really encouraging a biopsychosocial formulation of cases. Instead of kind of working in our own silos, we're working together as a team and getting a much more complex and thorough understanding of what's going on as a result, which then allows us to better plan for care. It does reduce barriers to care, including stigma. And that's also stigma within health professions because other health professions may not have the best understanding of mental health concerns. And that can be in itself a barrier to care. So when we're right there, when working closely with that team, it can really reduce those barriers. Also, and this is an important one, it has the potential to reduce healthcare expenditures. Of course, this is a huge thing that we've talked about for several years in our society. It's a big issue that we're going to be facing for many years to come. And some evidence suggests that this really has the potential to provide better care earlier and reduce some of the expenditures that occur both on the mental health side as well as on the physical health side. So we have some really good reasons for wanting to increase psychologists' participation in integrated care. I think it's also important to think about where is integrated care, because I've been talking about primary care, but this can actually end up looking a little bit different. There are some different ways this can occur, and this is called the 4-quadrant model, and this is one of the ways this has been presented. So most of the time, when we talk about integrated primary care, we're thinking of what really is quadrant 1 in this model, and I realize this is a little small. This is something you can find easily online. It's also in my slides if anyone wants to look those up through the app. But with quadrant 1, this is that traditional primary care setting. So at a primary care office, relatively low mental health needs, relatively low physical health needs. People are coming in for their well patient visits. They may be coming in because they have strep throat or something like that. But we're there, we're screening. It lets us detect problems early. So kind of moving on from there, quadrant 2, there's a much higher mental health or substance use need, but relatively low physical health needs. And in this type of situation, we might be providing this integrated care model within a more traditional mental health setting. So perhaps this is at a community mental health center, perhaps this is at a substance use treatment facility, but we also provide primary care services there. So we're helping people get that better access to care and really working through that team. Quadrant 3 is mental health or substance use needs are low, but physical health needs are high. And these might be settings such as nursing homes or skilled nursing facilities, other places where people have some pretty significant medical needs, but we're not necessarily seeing the same acuity of mental health needs. Then finally, we have Quadrant 4, and that's where across the board, people are experiencing a high level of challenges, both regarding their mental health as well as their physical health. And you're going to see people who are often dealing with serious mental illness, as well as major health concerns. So we're going to go meet those people where they are. That could be at places like state hospitals, or other inpatient psychiatric facilities, but we're also providing some pretty intensive medical services there as well. So when we say integrated care, we're not necessarily just talking about that specific kind of outpatient primary care model. So I think it's important to keep that in mind because we have needs in all of these places. And that really is our challenge right now. There is a substantial need for psychologists to work in integrated care. There is way more availability, in fact, than there are practitioners who are trained to meet that need right now. And according to the Society for Health Psychology, so that's Division 38, traditional psychology training doesn't actually prepare us well to work in these settings. And just to give you an idea of some of the competencies that you're dealing with here, I'm not going to read all of these, but you need the ability to work in a fast-paced medical environment. Traditional 45 to 50-minute sessions don't necessarily work well. You need to be able to get people in, get people out, see many patients throughout the day with a variety of needs, often stepping out to take warm handoffs or to do some consultation. So our traditional model doesn't necessarily prepare people for that. Another one is the ability to communicate effectively in a brief, practical, and focused style. If you think about the reports that we often teach our students to write, 7-page assessment reports aren't really going to cut it in primary care. So the things that we teach our students to do, we have a reason for teaching that way, and they serve a very important purpose, but it doesn't necessarily fit this setting. So it's important that we do provide specific training in integrated settings to prepare our students to later work in these settings. So where does Marshall University come in, which is where all the programs that we're talking about today are located? Well, Marshall is a relatively small university in Huntington, West Virginia. We are the second largest university in West Virginia, but if you're familiar with West Virginia, that's not necessarily saying a lot. Yay! We have a little over 13,000 students at the university. But something very nice about where we are is we do have an affiliated medical school and other graduate level health professional programs, including physical therapy, including speech pathology, social work. So we have several other programs with which we're affiliated. So that's definitely an advantage to where we are. But you can see one of our biggest challenges here in this little map. So that's Huntington with the star. And that little radius around it, you can kind of see what's nearby, and the answer is not a lot. The closest big city is Lexington, Kentucky, which you all know is a huge, thriving metropolitan area, right? We also have Columbus, Ohio, but once you kind of get past those two, there's not a lot nearby. So we're a very, very rural area, and we have a lot of significantly underserved areas nearby. So this presents some kind of unique challenges that we might face in terms of providing some of these opportunities for our students. So it's really encouraged us to be very creative in how we approach integrated care training. And we try to be very mindful of where we are when we are training our students. A primary objective of our program is to prepare our students to provide high quality mental health services for people who live in rural or otherwise underserved areas. So this is a primary focus of our program. So this is also taken into account as we kind of design our training experiences. So what we've really come up with is a balance of different experiences. So we have traditional practicum experiences in integrated care settings, as you might expect. So just some examples of a few of our partners. We work with Valley Health Systems and Cabin Creek Health Systems. Both are FQHCs and they're pretty big health systems, and they have primary care offices located throughout the region, many of which are in very rural areas. We also work with the local medical center. So we work with Marshall University Internal Medicine, Marshall University Pediatrics. We have a long-standing relationship with them. And so our students get those traditional practicum experiences. What we're going to talk with you about today are the more innovative experiences. So we have interprofessional education, we have Marshall Medical Outreach, and we have Senior Fest. So what we're going to do from here on is we're going to break those apart and talk about each one of those. So first up is going to be Dr. Keith Beard. He's going to talk about the interprofessional education program. I'm going to come back up and talk a little bit about Marshall Medical Outreach. I should have introduced myself earlier. I'm Brittany Kennedy. And then we have Dr. Penny Kuntz, who's going to talk about Senior Fest. And then finally, Dr. LaPearl Winfrey has very graciously agreed to be our discussant and try to help pull some ideas together from this. So I will turn things over to Dr. Beard.
Got it. Okay. Hi, everybody. I am Keith Beard. I'm going to talk to you about interprofessional education, or we call it IPE. So you'll hear me using that quite a bit rather than saying it all out there. For us, it includes 8 different professional programs. Some of these programs are bachelor's level, some of them are master's level, and some of them are doctoral level with it. All of the students who are in these different programs, we meet on 3 separate occasions, and we do this in an effort to establish knowledge and application of preliminary concepts related to interprofessional collaboration and practice. So we have about 400 students and about 40 facilitators. What we do is we break them up into groups of 10, so we end up with 40 groups with 10 students in each. So why do we do IPE? Well, there are several reasons there, and I'm not going to go through all of them, but one, of course, is to create a climate of mutual respect. Another is it's a real-world simulation. It also helps reduce medical errors and those sorts of things. So prior to day 1 with it, what do we have them do? Well, we have a couple assessment instruments that we have the students do, and then we also have some YouTube videos that we have them watch, and I included, so you can go back into the PowerPoints, the links to those YouTube videos if you want to go see them. They're short. And then we also ask them to think about how they would describe their role in a healthcare team and be prepared to talk about that. So then day 1, this is what our schedule looks like, and I'm not going to go through every aspect of that, but I do want to point out a couple things. One, the team building activity. That's just a basic icebreaker activity that you could come up with, but the key is to make sure that there's a team component to it, that you're not just doing an icebreaker where they're introducing themselves and nothing else. They have to work together in some way with it. Also, the team root cause analysis. This is a brief case. It's usually like about a paragraph that we give them, and it's about a patient, and she's discharged, and then there's problems, and she ends up getting readmitted with more complications, and what happened is that the different professions didn't talk to each other. And so they read this short little paragraph, and then we ask them questions about, why did this not go well? And what we want is, well, it's the result of the different professions not working together. And then we ask them, what could their discipline have done differently to help that woman not have additional complications and end up back in the hospital again? And then we do a team debrief, and that's where the facilitator comes in. The faculty facilitators, they provide feedback on the communication. It's not about, and we emphasize this a lot, it's not about whether the students are right or wrong in what they're saying. That's not the point. The point is them working together. And so you're encouraging those who are quiet to talk more. You're noticing who kind of takes leadership roles, who the different roles that people take on in that group setting. Day 2, The goal is to have a team-based approach for them to develop a plan of care for a patient for her remaining stay in the hospital and discharge plan. Again, I'm not going to go through everything with it. I do want to mention, though, again, this is for the standardized patient that's going to happen on day 3 of the IPE event. Also, again, with the team debrief, we're reviewing the discussion that went on. They're coming up with their plan. We're giving them feedback on their communication with each other, how they could do better with it. What we tend to find here is they go, well, this is what I would do and what I can do with them. This is what I can do with them. This is what I can do with them. But they don't talk about what is pharmacy doing that's going to influence what social work is doing, and how's that going to influence what dietetics might be doing, and again, focusing them on just opposed to here's what I'm going to do as a nurse. What are you doing as a nurse that's going to influence the med students or the psychologists? So we're giving them that sort of feedback. Day 3, that's the big day. You'll notice, again, I just put the schedule here so you can see how we do it, and I'm not going to go over it in a lot of detail with you. But because we have so many students, we tend to break it up over 2 days and run concurrent sessions. So we have 10 groups during the first time period and 10 groups during the second time period on day 1. So there's 20 groups that have gone. Day 2, we have 10 groups go during the first time period and 10 groups go during the second time period, and then that comes up with our 40 total. So it gets a little tricky there trying to get everything scheduled with it. But we run back-to-back sessions over 2 different nights with it. With this, of course, the middle part there, the team meets with the patient, and we have a caregiver, standardized patient, mock patient with it. And we instruct the caregiver and the standardized patient to never go according to their plan. So no matter what the students come up with as their discharge plan, we have the standardized patient or the caregiver come up with a problem with it. So if their plan is to discharge the patient to a rehab facility, we have the patient say, no, I don't want to go to a rehab facility. I want to go home. I want to go home. I want to go home. If they say, we're going to discharge her to home, the caregiver says, she can't go home. I work all the time. That's going to be a problem. You can't do that. So no matter what they come up with, we make sure that the standardized patients throw a curveball with them and try to get them to think about how they would handle things. And it's interesting to see kind of what they do with that, because oftentimes they'll turn to the psychology student because the standardized patients get upset and they're acting, and then they're like, what do we do? They're showing emotion with it. So again, the goal with whatever their discharge plan is not whether they're right or wrong. The goal is them working together to be able to come up with something. So I want to talk briefly about some problems and challenges that have gone on over the years. These are not things that happen all the time. We've come up with some ways to resolve some of them. I'm going to talk about that in the next slide. So I don't want you to look at this and think, oh my gosh, we're never doing this. Look at all these problems. But these are things that have come up, and I want to talk to you about them so you can be aware and then talk about how we fix some of them. One is scheduling. That's always an issue. So we're trying to coordinate 8 different programs and their schedules with exams and assignments and comps. The med school at our university actually works on a different schedule than the rest of the university, so that causes problems. All the facilitators, they have schedules that we're looking at. The university schedule with holidays and breaks. Also, in terms of scheduling, just finding rooms for 40 different groups can sometimes be difficult. Getting enough facilitators is another issue. We like to think that our faculty are ready and willing to step up and help out with everything, but these happen in the evening times, and they have other commitments, or they aren't interested or don't see the importance of IPE, of interprofessional education. Different size programs, and so some of our programs have 80 students in a cohort. Some of them have 15 in a cohort. And so we have some teams that have 2 medical students or 2 pharmacy students or 2 physical therapy students because they have so many in there, but they have 1 or no social workers or psychologists with it. Those 2 programs at our university are small. We usually have about 10 to 15 in those. And so there isn't representation in each of those fields there. And then the development of the case, all the different faculty who are on the IPE committee are coming up with the case, and we make modifications, and we send it around, and it's revised, and things get missing, and people don't always save things or review it, and from one draft to the next. And then we've had some problems with the standardized patients. Sometimes it's difficult to get the standardized patients. We've been lucky with that we usually leave that to our medical school because they are using standardized patients in a lot of their other activities, and so they have a pool of people that they've been able to do that with. And also the feedback from the standardized patients, which we have them do after the third session where they're meeting with them, sometimes is harsh because they're not focused on what the goal is. They're saying, you told us to do the wrong things. That's not going to work. But that's not the goal. The goal is how well they're working together. What's interesting as a side note with this is working with the faculty committee, and each of the 8 programs has a representative, and I'm the one for our program. It's very similar. It mirrors what the students are going through in terms of working together and collaborating and putting this all together. So what helps and what things have helped? Setting the dates early. We usually set the dates for our 3 days at the very beginning of the fall semester. So that way everything can get scheduled around those particular times with it. We also designate a person who's responsible for everything and then who's responsible for each piece. So we have somebody who oversees everything, another person who's in charge of putting the case vignette together and making sure people get the different pieces, another person who's responsible for scheduling the rooms, another person who's responsible for scheduling the different groups with it. So everybody kind of has their own part, and then somebody else is overseeing to make sure everybody is doing their little part. We do monthly meetings, which has been really helpful. It helps us stay on track with things. We were doing them in person. This year we've been doing them through Zoom, through video conferencing. I don't know that I like that as well, but it's been working, and it's easier with other schedules that we're doing. Another thing we do is after the last session, we have another faculty meeting to go through and debrief how we think it went, what do we want to do for the next year. We've changed it up sometimes. One year we decided to do 2 days instead of 3. We've talked about doing one long day, like an all-day Saturday thing. And so we talk about kind of what we want to do for the next year and how we want to change things with it. And then we've also done some facilitator training. So we actually have an online facilitator training. It's a PowerPoint, and we're talking over it. And so it kind of goes through and focuses the facilitators on what we're really wanting to do and what we're wanting them to do. So are there any quick questions about IPE and interprofessional education before we move on to the... Yes?
At what point in the PsyD program do they fix it?
We do this during... we actually double our cohorts because we have so few, and it helps fill the groups up. We do this with our 3rd years and our 4th years.
They've already had some practice.
They've had some, yes, absolutely, yes.
Had that early on.
It's, yeah. And we see that with the nursing students, our bachelor's level that are there, and we see that in terms of kind of, there's a real difference, yeah, in what they're able to do, and yeah.
You said this, but is this required for all of your students, and likewise for the students in the training program?
It is required, and all the programs do require it for them. And so we set that up. We try to actually, we have a rural and community class, and so we try to take designated time from that because, again, our students are busy. We pack their schedules full, and so we take designated time for that class and say, no, this is a part of that class. Some of the other programs actually have this also as part of their classes, and so it's part of a grade, and so it kind of makes them go with it.
I appreciate this very much. Thank you. To IPE at Philadelphia College of Hospitality Medicine with our study.
Excellent.
Well, I was wondering who manages the budget for this, or do you have a budget? We have found that's one of the challenges. I oversee it for our medical school and for our PsyD program and mental health counseling, but I was just wondering about your budget.
What's been nice is we really don't have a budget with it.
Same way.
Yeah, with it. The standardized patients do get paid, but again, the medical school has said that's part of their commitment to it, and so they take care of the cost for that. We have talked about some grants and adding that into the grant to pay for the standardized patients. We can reserve rooms on campus and other areas for free, and so that's that's no cost to us.
We're pretty much the same, although our psychology funds the Virginia Gas and our graduate assistants for helping us with that and coordinating it. But and we've gotten the provost, who is a DO, to kick in money for pizza because we found the only way.
Excellent. You feed them and they will come. Yeah.
We feed them.
Yeah.
Seriously, all our satisfaction services. They said it's late, we're tired. I'm like, our students are there every night at this hour. But you feed
Yeah.
them, and that came from there. But I was just curious about
Yeah.
the budget because that's one of the challenges that we face.
Yeah, the biggest has been the payment for, and then it's been like, is the med school going to pay? Are they going to do it? Are they going to do it? And I talked to LaPearl. It's a nice perk
Okay. Great.
with it.
Thank you.
Yeah. Yes.
Any sense of whether this factors into the kinds of internship choices students make having had this experience, and are they able to parlay this experience into how they present themselves to internships?
Excellent question. We're going to talk about that a little bit later. We actually have done some surveys of our current students and alumni and gotten some of their opinions about how this has influenced the different things that we're doing, how that has influenced the choices that they've made. So you're going to hear some of that. Sure.
Keith, is there any coursework that they have to do prior to them taking this experience, like the developmental behavioral needs class or anything like that?
We don't have anything required. They are in the middle of taking some particular types of classes. So this is happening at the same time they're doing the rural community class. Also, depending on the year, we shift classes around. They're doing the behavioral health class when they could be doing this. But nothing is really prior to it. But oftentimes in the middle of it. So thank you. If you have other questions, you're welcome to ask me afterwards with things. So now we are back with Dr. Kennedy. Oh, you got your...
All right. Thank you, Keith. So we are going to leave some time for questions between each one, but we're hoping to have more time for questions at the end because we're sure that you're going to have things that you want to know to help implement some of these ideas if you decide you're interested. So next up, I'm going to be talking about our Marshall Medical Outreach Program. And this is a really interesting program to be working with. You can see a picture that's actually one of our faculty members in the middle, surrounded by 4 of our students. This was at the November Marshall Medical Outreach event. This is a monthly thing. And just to give you a little bit of background and history before I tell you about how it works. So this is a quote from the website for this, and the goal is to provide affordable health care to a group who is among the most underserved, so individuals who are homeless, unemployed, or otherwise low income. So that is the stated goal for this program. This was first developed in 2011 by our affiliated medical school. It is run primarily by the family medicine department, or it was originated, I should say, by the family medicine department. But services over time expanded to include kind of other medical areas. So they brought in pharmacy, they brought in ophthalmology, they bring in dermatology sometimes. I think maybe they've had dentistry there on and off before. They also expanded to coordinate with other community groups. So there'll be food provided, there'll be clothing drives, there'll be different things that might be donated by different organizations. Psychology became involved in 2015 after we learned about this service. So we actually approached them. They didn't approach us. And it's been kind of an interesting process to get involved. So that's a little bit of history. So the way MMO works is it is a student-led effort. So faculty are present, we provide supervision, but the students are the ones who are doing the organizing. They decide the dates, they organize between all the different kind of community groups that might be participating, all the different services that are going to be provided. They figure out who's going to be doing what on a given day. So the students are really the ones in charge of making sure these events run. This does occur once a month. It is provided in the parking lot of a local church, and that's where that picture is. So they have a bunch of little tents that they set up as exam rooms and waiting areas and so forth. They have a van that comes in where they can do kind of OBGYN services. So just some different things going on there. And they do provide free services to anyone who shows up and wants those services on that day. And patients can have a number of different things available to them. That includes food, clothing, medical consultation, psychological screening, eye exams, flu shots. They've done some smoking cessation stuff before. So they just have a number of different things that are going to be available to them. So people can come, they can receive whatever services they're interested in that day. So you don't have to have everything. You can pick and choose. You can say, no, I don't want to see the psychologist, or no, I don't think I need glasses. You get what you think you need. So the process of integration. At this point, I'll start with the really good stuff. We're actually seeing a really close level of integration between the different services that are there. Starting off, we felt like the picture down on the bottom left, we felt like we were kind of off in the weeds somewhere observing what was going on. And we did start going in with this perspective of, we're asking to be here. They haven't invited us, they're kind of tolerating us. So let's see how this works. Let's gently kind of begin to insert ourselves into this process. So we did start off kind of observing, seeing how it worked. And then over time, we started seeing opportunities. So we took on more of a consultative role there for a while. And then they started to get to know us. So at first it was more of, this person is crying. Can you come talk to them? That was probably the most common thing that brought us in. But then we really began to become more involved, and our students actually began working on the organizing group, and they kind of were able to talk themselves into a much closer collaboration. So now medical students and psychology students work together in teams. They go in to see the patients together. So every patient gets to see both. They can decline either service. So sometimes they go in and they're like, actually, we just wanted to talk to the psychologist. And the medical student's like, cool, I'll just sit here and watch. So it does depend. They're not required to talk to everybody, but each gets to see and learn from the other. So we're seeing closer and closer collaboration. So lessons learned from this, well, there are a lot of benefits to this program. It brings graduate psychology students into direct contact with early medical students. And I really like kind of that emphasis on early, because these are students who are just beginning to learn their fields. And by showing them integration early, I think we have an opportunity to really influence kind of their understanding of how psychology can help support their services. Our students can also be earlier in the program when this happens as well. So we don't require specific coursework before they begin attending MMO. They can come in their first year while they're still getting some of their basic courses and observe, so they can see what the more experienced students are doing. So it begins that contact early. It allows for mutual observation and understanding. So the medical students see what we do. That can help reduce that stigma, increase the understanding of the services we can provide. Our students get to see what the medical students are doing. So they have a much better understanding of some of those biopsychosocial issues that are coming together. This also facilitates growth in principles common to integrated care. So that close collaboration with others is really emphasized. So the students are encouraged to stay kind of close by their medical students, to chat with them, to kind of begin building relationships with them while they're there. This also encourages our students to do brief screening and intervention. So this is a setup where there is really not a clear mechanism for follow-up. So we're not going to have someone come back in a week to meet with us and do therapy. So how can we briefly screen what's going on? How can we identify what the needs are and provide referral or else a brief intervention to get this person to where they need to be? So that might be doing some brief education on sleep hygiene, or some information about how their use of substances is impacting their functioning. Maybe it's about, okay, so you've been diagnosed with bipolar disorder and you've been prescribed meds, but you haven't been taking them. So here's why this might be a good idea. So just some brief intervention with people. So that's the good part. The challenges that we faced, I've already kind of indicated. So getting buy-in from supervising physicians was probably the biggest challenge. Yeah, Penny chuckled a little bit. So this was housed within the family medicine department. And the main physician that really worked with this program really was not particularly on board with psychology being present. He really didn't see the value of having psychology there. It was more the kind of coordinator for the event who's like, oh yeah, sure, more services, let's bring people in. And he's like, fine, you guys can come. We're starting to win him over. It's 2019 now, so 4 years in, we're starting to win him over. They do a circle at the end, and he talks about the good things that have happened. Did not mention us for the first 2 years, but a few times now he's like, and psychology really helped with this particular thing that was going on today, so thanks for being here. So it's starting to get through. So that buy-in can be challenging, but if you're persistent and if you really demonstrate your value, you could win them over in the end. Going along with that, just getting a place at the organizing table in the beginning. And our students have been so valuable in this. Since this is a student-led event, it's been so important to have our students at those kind of organizing meetings with the medical students. We've had a few that have become very involved with that and have been really instrumental in making this work and really furthering that collaboration. So if you have students who are willing to kind of champion your cause, that can make a big difference. All right, so we have a few minutes for questions, if anyone has questions.
So is this optional or is this required?
This is optional for students, so it's purely on a volunteer basis. It's 9 to 12 a.m. on a Saturday morning. Rain, shine, snow, sleet, any weather, they still have it. So we don't make people come, but most of our students do volunteer. It's very popular. We generally get dates a few months ahead of time, and so we send them out for a semester. It usually fills up within about an hour from when the email goes out saying, hey, these are the dates.
And since you allow first-year students to do it who really don't know
Mm-hmm.
how do you ensure that they're not engaging in activities they shouldn't?
We have supervisors on site, so we have 2 faculty supervisors every month who are there. Yep, and frankly, the students are scared to death.
I will say with the first year students, we have different roles that we let them take, and we only let them be observers.
Yep. Yeah, we have 4 slots that we allow student clinicians to sign up in, and then 2 observer slots. So
sorry for to say this, but physically, are the psychology students only teamed with a medical student, or is there a standalone psychology table where the client from the community could just come to see psychology?
We've been really focusing on the integration piece at this point in time, though we've talked about having our own little tent that we could take people to. So it's definitely an area that we're looking to move into in the future. But I think we need to be a little more established for now, but that's definitely a great way to go. So.
I was going to say, we have not the same thing, but something sort of similar to our med school. It's called the STEP program. So our psychology students, they go with the med school students, and I think it's also the Department of Social Work. But they did interview together, they learned quickly beforehand motivational interviewing. And then from there, then they meet with their client and go through a screening question so it's sort of like they're learning motivational interviewing that they also do with the people, or what kind of things are the psychology students in med schools?
We give them a lot of flexibility. So just depending on what people are coming in with, the needs might vary really considerably. So sometimes they're just talking with people about making sure basic needs are met. Sometimes it's more about making sure that they have connections to care that they need. Sometimes it is a little bit more psychologically focused, and they may do some motivational interviewing, but we give them a lot of freedom to kind of assess and then determine what they need to do. Other questions? All right. So if you like going out in the cold weather on Saturday mornings, I highly recommend.
Sorry, that was a lot.
There's definitely varying interest in it. So some people don't do it particularly often. Some people absolutely love it and would do it every month if we let them. But we do also have some grant funding to support faculty stipends.
We did have a GPE grant, and we did put in that GPE grant for payment for the supervisors. And that is a little bit of an incentive. I don't know that it's a lot. I think there's a climate of an expectation that you're going to do your turn, you're going to do your part. And so everybody, at least one, all the clinical faculty at least once during the year will do it.
So, other questions?
They decide on a Saturday. We have several faculty who that's their day of worship would not all agree to do that.
That's how the medical school had been doing it for several years. Our area is heavily kind of Protestant Christian. So I think for many of the students who were populating the medical school program in particular, that just seemed like a logical choice, but that definitely wouldn't necessarily work for people of other faiths.
I will also add to, in terms of incentives, we're evaluated in terms of faculty for tenure and promotion as well as raises on teaching, research, and service. And this counts as service. And so that's been decided upon within the university. And so it's like, this is going to help you with P&T or with raise.
All right. Well, thank you. I'm going to turn it over to Dr. Penny Kuntz now to talk about Senior Fest.
Thank you. Okay, I'm really excited about talking with you about Senior Fest. I always kind of get excited when I get the opportunity to talk about services for senior adults. That's just kind of near and dear to my heart, and Senior Fest speaks directly to that. You can't see it very clearly, but that's a snapshot of what the main floor of Senior Fest looks like. It's a lot of organized chaos. And so I'll talk to you a little bit. I want to explain what Senior Fest is first, and then talk a little bit about our role in Senior Fest and why we think it's so important to have this event in particular. Senior Fest is sponsored by Cabell Huntington Hospital Senior Services, and Cabell Huntington is the largest medical center in our region. That includes, as you saw on Brittany's slide, southwestern West Virginia, northeastern Kentucky, and southeastern Ohio. It is an interprofessional health fair for adults over age 50 from our entire region. Some of the medical services that seniors can receive when they come to Senior Fest include things like bone density screening, flu shots and other immunizations, cholesterol screening, mammograms, prostate screening, diabetes screening, and health education talks. So all of that is going on inside the medical center, and then outside there are activities that promote socialization for the seniors. They have live music, for example, cakewalks, pretty old-fashioned, but they love it, and health exhibitions. For example, a couple of years ago, they had a big inflatable colon that the seniors could walk through, and it gave them information about the importance of colon health screenings. And so everybody was talking about that. Have you gone through the colon yet? So that was really popular. And the hospital provides free lunch for every attendee and every healthcare provider who attends. So Senior Fest began in 2009 with about 400 seniors attending that year, and it has just grown by leaps and bounds. Last year, over 2,300 senior adults came for healthcare screenings, which is tremendous. So this slide is taken directly from Cabell Huntington Senior Services, and it is sort of their expression about the purpose of Senior Fest. And you can see there's some of the screenings that they receive. It's a great way, they say, for seniors to gain knowledge about their health options, and importantly, it's free of charge. All of those screenings and services that they're provided. It's really all about prevention, early intervention, and promoting health literacy among our senior adults in our region. Okay, so what are some of the reasons that Senior Fest is an important opportunity for PsyD students, or the opportunity to work with senior adults, period, in our PsyD programs? We're all aware that the U.S. population is aging, with the first group of baby boomers hitting age 65 in 2011. It's estimated that those over age 65 and older will represent about 21% of the U.S. population by 2030. And for us and our program, working with seniors is particularly salient because we already in West Virginia have the third highest percentage of seniors over age 65 in the U.S. At about 18% already. So it was particularly important for us to begin to think about how can we prepare our students, many of whom stay in West Virginia and practice, to work with seniors. It's believed that about 20% of U.S. adults age 55 and older have some type of behavioral health concern, with anxiety, depression, and cognitive impairment being the most commonly seen. That's, of course, particularly critical for young psychologists in training, given that behavioral health conditions are widely under-recognized, under-treated, or not treated at all in senior adults. So it's really very vital that we're preparing our students to treat this growing underserved population. This is a population that's already highly represented in integrated care settings. So this gives them practice in providing services to that population. So how did we become involved with Senior Fest? What has our journey been like? I first taught our geropsychology class in 2012, and just 6 years ago, well, 7 now, we had a fairly limited number of practicum sites that provided opportunities for our students in integrated care, much less the opportunity to work with seniors. And so I was really interested in how could I incorporate a field experience for the students in my geropsych class, where they would leave the course having had some real life interactions with older adults, not just simulations. And so one morning, I saw a commercial on the local TV channel advertising Senior Fest. It was very fortuitous. I did not know about it before then. And so I thought, well, I wonder if they might have room for one more mental health provider at Senior Fest, and would they let us come and play? And so I called the director of senior services at Cabell Huntington and asked her, what type of mental health services are you currently providing at Senior Fest, and would you have room for one more? Well, I was saddened and surprised they had no mental health screenings at Senior Fest at all. And she was delighted that I wanted to come and bring a group of students. And so that first year, I had 12 students in my geropsychology class, and I didn't know how it would go at Senior Fest, and I tried to prepare my students for the possibility that the seniors, I said, first of all, they're not coming to see you. They're coming to get health screenings, and they may not be interested in seeing you at all. And if we can see 25 seniors, I just kind of threw that number out there. I said, if we can see 25 seniors, let's consider that a big success. And so I kind of tried to temper their sort of disappointment a little bit. We were shocked. We saw 125 seniors that first year. We did screenings for depression and anxiety, and so we administered 250 screenings that very first year. We added screening for mild cognitive impairment 2 years later. And so every senior who volunteers is screened for depression, anxiety, and mild cognitive impairment. And those are the screenings that we use. So since 2012, we have screened over 900 senior adults and administered over 2,000 behavioral health screeners. And so those are the screenings. We use the Geriatric Depression Scale, the Generalized Anxiety Disorder 7, and the MoCA, the Montreal Cognitive Assessment. We have students. It has outgrown my geropsychology class. And so now what I decided to do, I'm the director of our psychology training clinic as well. And so I opened it up to all of the clinicians in the clinic, and it's also outgrown that. And so now I open it up to all of the current students who want to participate. And I have so much interest from our students, I have to schedule them in shifts. It's really amazing what the student response to it. So just to kind of wrap it up, what has the experience offered for our students? We do have a limited number of opportunities in our traditional practicum placements to work with seniors. So this provides that hands-on experience. Even if it's just for one day, it gives them clinical experience working with senior adults. They learned some really important information about seniors, such as if your event begins at 8, you better be there by 7 and ready to go because the seniors will be lined up at the door. And we learned that the first year. And you also learn how to be very strategic with your giveaways because the seniors really like those. And they like those by the handful. And if you aren't strategic, you'll run out within 30 minutes. I also learned that the hard way when I had to send students out, go get more stuff. So, but more importantly, every year the students talk about how their attitudes and their beliefs about working with senior adults are challenged and modified after spending just one day working closely with them. Those students not in integrated care settings get at least one opportunity to work for a day in a medical setting, and that can change some attitudes about that as well. Last year, we were located between orthopedics, who was doing bone density screenings, and internal medicine, who was doing diabetes screenings. The environment is fast-paced. Again, sort of one of the competencies of working in integrated care. They get opportunities for intervention, referral, opportunities to educate seniors and their families about the connection between mental health and physical health. It's a community service, a way for them to give back to the community. And beginning in the third year, we had received permission from our IRB, and we've been collecting data every year. And so the students get the opportunity to work in a long-term research project as well. So it's been a great experience. That picture on the bottom is just one small group of students who attended, and the top picture there, I know you can't see it very well, it's the day I got an opportunity to do a health talk for the seniors and their families, and that is a clown that was there just kind of roaming around that day. So, and of course he came up to me. So what questions might you have about Senior Fest? Yes?
How do you handle referrals for positive screens? You just give them a sheet, and do you have kind of a ready supply of places that they can access?
Right, we do. We deliver feedback results to everyone who is screened, and then we provide a sheet of referral sources. And some in particular, we have a closer relationship. Some we refer to our clinic, to our university clinic. And others, actually the hospital, Cabell Huntington, has a counseling department there. And so we can refer them there to the hospital, and then other resources. And some we refer for additional testing, assessment, particularly those who are on the screen fairly high on the MOCA.
And is part of your research study following up on the...
No, we really don't, because it's we do anonymous data collection, and so we really don't have a mechanism for following up. I wish we did. That would be great to know. So, any other questions? Okay, thank you.
Okay, thank you, Penny. So at this point, I'm going to hopefully get this on the slide it needs to be on. Oh, okay. All right. So I'm going to talk pretty briefly about training outcomes. I realize it's about 7 or 8 minutes to 4, and I want to give our discussants some time to talk as well. But just very briefly, we wanted to see what the impact of some of these experiences were for our students. So we did a brief survey. This was approved by our IRB, and we just asked about the possible integrated care training experiences they'd received, traditional training experiences, so practicum experiences, as well as internship, as well as the 3 that we've talked about today, so Senior Fest, IPE, and MMO. The content of this asked about participation in the events, the content knowledge that they believe that they gained from participating. So if with Senior Fest, do you feel like you learned more about this population, for example, by attending this event? Integrated care knowledge, and then employment decisions. We used a 5-point Likert scale, so a higher score would indicate that they believe they gained more from the experience. We sent this to all current Marshall PsyD students and alumni via the listservs that we maintain for communication purposes. We had a total of 64 people participate, 39 alumni and 25 current students, and you can see kind of the breakdown of who participated. Apparently the 2014 cohort is really participatory, but generally we were getting like 3 or 4 people from each year responding, and then a little higher, of course.
How many graduate each year?
We generally accept about 10 to 15 per year. In terms of graduating, about the same, 10 to 12 per year. So I'm going to go ahead and skip to results. So what you can see is some of these were implemented. In fact, most of these were implemented relatively recently, so they weren't available for all those students who had participated. But they were available for many of the people who had. When we look at the actual ratings that they gave these sites, we can see pretty consistently that people felt that they were gaining knowledge from attending, and they felt that they were gaining kind of more confidence in their experience with the population. So when you look at these comparisons, you can see that there really aren't differences between some of the innovative experiences, IPE and MMO in particular, And the traditional training experiences, so practicum, internship, they're giving similar ratings to how they contributed to their knowledge of collaboration as well as their knowledge of working with specific populations. As we would expect, Senior Fest was a little bit different because that doesn't focus on collaboration. It just focuses on kind of experience with this particular population, and that's how those scores break down. So what we were hoping to see from this, and what we did see from this, is that these are really legitimate integrated care training experiences that add to knowledge just as traditional practicum experiences can do. Even though it's less intensive, it still gives students that opportunity to get in there and learn about it. Also, it seems to be influencing people's choice of work settings. So you can see for our alumni, we had everyone report where they're currently working. A significant proportion of our students are working in integrated care settings. That includes medical centers and primary care. And that's probably a bit of an underrepresentation because some of the people in the other category could potentially fall into that, as well as some of the people in some of the other categories are still actually sometimes doing some integrated care work, even though they don't identify that as the primary part of their job. They considered integrated care training very influential in selecting their employment. So those who had had those experiences were very interested in continuing that in their future job. All right. So I've tried to go through that really quickly. I know we started about 10 minutes late, so hopefully we still have about 10 minutes for Dr. Winfrey to kind of wrap things up for us, and then we'll kind of take some more questions at the end. All right.
Okay. First of all, I want to thank Keith, Brittany, and Penny for inviting me to be their discussant. And in the interest of full disclosure, I should indicate that Keith is a graduate of my program, and so I'm happy to see that the long arm of School of Professional Psychology at Wright State is out there and doing great things. 2 years ago, as a part of the NCSPP keynote panel, I said some very cautionary things about integrated primary care, if not disparaging. I was and continue to be concerned about us putting too many eggs in the primary care basket for the future of psychology. But I am hopeful, and two things have helped to motivate that hope. One is certainly reading this presentation and seeing how creatively integrative primary care settings have been used and are being used to train students. And another was an interview for a recent faculty candidate at our program, and she's working in a medical care setting. And when I kind of shared some of my concerns with her, but she said, however, if we're at the table, here is what we can do. And she described very creatively how she was using a community participatory action paradigm to design and implement needs assessments to help clarify problems in an underserved community, how to gather data to present for funding sources. Also, how then to design interventions and consultations to address some of the problems that were identified in needs assessment, and as well as how to integrate into all of that, especially intervention and consultation, outcome measures so you could improve the effectiveness of what you're doing. And I remain hopeful because it was I think it's pretty clear to me that I don't know of any other discipline that will train people to do all of those things and try and do them well. And that's something that we have, and I think that we have to advocate around the value that we can add, because our students do come not only just well trained but broadly trained to address needs. But psychology has been slow to come to the IPE fold. Back in looking at the NCSPP original competencies, we had management and supervision, and we had consultation and education. And supervision and consultation were implemented in the old APAG and GNP, which roughly ran from 1996 to about 2016. At the Competencies Conference, so there was no mention of interprofessional education at that point. At the Competencies Conference, in 2002, for those of you who've been around, it was a major conference, and all the training councils came together to kind of take a look at what competencies are we using. There was a work group in interprofessional collaboration, consultation. I was a member of that group, and it resulted in a 2004 publication in the Journal of Clinical Psychology. I just want to read to you what their definition of interprofessional collaboration was, because I think they really hit on what some of the things that you guys are finding out now, and maybe we need to attend to for the future. Maybe I should just close this. You want to just? I don't want to. Okay. They define interprofessional collaboration as education, training, scholarship, practice, and other professional activities that prepare and call for psychologists to work in a respectful, collaborative, integrative, and informed manner with other psychologists and members of other disciplines and professions, and B, with individuals, groups, systems, and organizations that may have diverse values, clinical perspectives, or other worldviews, and accountability to different constituencies. And I think two things to note about this definition is that it does extend beyond the individual to systems and organizations, and B, that the group chose to use the word interprofessional as opposed to interdisciplinary, so as not to privilege any particular discipline and to keep the focus on integration across disciplines. 2011, let me see if I get this right. This is the Interprofessional Education Collaborative issued a report on competencies required for interprofessional education. Now, APA was not a member of this group in 2011, although they were signatory to the report. This group identified competencies in 4 domains: values, ethics, roles/responsibilities, interprofessional communication, and teams and teamwork. By 2016, this collaborative had expanded from traditional health professions like medicine, nursing, to include allied behavioral health disciplines like OT and PT, and by 2016, APA was also a part of this group. Now, in 2017, of course, we got the new standards of accreditation, and the profession-wide competencies do include a competency called, and this is a pretty inclusive, consultation and interprofessional / interdisciplinary skills. And for doctoral students, they have to demonstrate knowledge of consultation models and practices as a requirement for that competency. For doctoral students and interns, they have to demonstrate knowledge and respect for the roles and perspectives of other professions. And for interns at the internship level, they must demonstrate that they can apply this knowledge directly or through simulated practice. I think most of our programs that are doing this have probably met the intern kind of criteria for meeting this new competency. So I think we've seen really 3 nice examples of how one can go about implementing interprofessional competency in our programs. I don't want to just, reiterate what you've just heard, but let me just end with some considerations for the future. In thinking about this, I think it's pretty clear that we need a paradigm shift in our training. I think Morgan Samuels in the advocacy panel kind of hinted at this. We can't train our students for these new and emerging and cutting edge when they have to go to an internship that says that you have to have so many hours in intervention and traditional assessment. And so that, our internship and also our accrediting bodies need to catch up with the other kinds of things that we are doing as we are defining who what health service psychologists are in the 21st century. Another thing is that we need to be clear on our definitions. Are we all on the same page? Is consultation interprofessional psychology? Is it consultation? Is it interprofessional skills? Is it both of these things? Because I think most of our programs are probably starting to require, most of our programs, because of the old GNP, have a course in consultation. We may not have experiences or academic coursework in interprofessional education. Those two things are closely related, but I think we all need to use, because you start to see different terms all over the place. So-and-so's report, our own accreditation standards, different programs talking about implementing this in different ways. I think we need to attend to expanding training to explicitly consider larger systems, as did the definition from the Competencies Conference in 2002, so that our students need to be trained to focus on community-level interventions with organizations beyond just the family. And this is very important, I think, if we are to continue to have to look at issues of working with marginalized populations, having social justice as a part of our drive to do good work. We can't do that by just focusing on individual paradigms. Another issue, and this starts to get into a resource issue, is but how to provide appropriate experiences for all of our students. When you have 10 or 15 students, there's one set of kind of pressures, but when you have 25 students, or when you have even more students in your program, how do you get everybody to have some kind of experience in this area? Is this a course? Is this a module? Applied experiences, so thinking about how to do that across the board. We also, I think, need to expand our reach to impact healthcare policy, decision making, and especially resource allocation. We heard some about that this morning, earlier this afternoon in the advocacy skill workshop. That in terms of working with other professions, and again, as a 2002 competencies definition indicated, some of these professions are outside of psychology, maybe outside of healthcare altogether. We need to be talking to those decision making, particularly, say, our legislators, who are allocating funds and deciding where money goes and how much money goes to our programs. And clearly, I think psychologists have been severely underfunded. It also means more focus on advocacy, which is closely tied to the policy issue. Advocacy as a potential career. There's no reason why we couldn't be thinking of training lobbyists in psychology, in behavioral health. Advocacy as a service to the profession, so that as a part of tenure and promotion, this could count as your service, and advocacy even as an ethical obligation to ourselves and to our students. So with that, I'd just like to end there, and thank you very
much. Well, that's fine, thank you. Well, and thank you to all of you for coming this afternoon. I realize that because we started a little late, we're ending a little late, but are there other questions that anyone would like to ask before we wrap up? All right, I brought some cards with contact information if anyone would like to take one so that you can get in touch with us later on to ask us questions. Please feel free to do so, but we really appreciate you coming this afternoon. So, thank you.